Good afternoon, good morning, good evening, everybody. I am so glad to be here with you to host this webinar, Ophthalmic Manifestations of mpox, What Clinicians Need to Know. My name is Dr. Anna Yaffee, and I am the Adult Care Work Group Co-Lead for the National Emerging Special Pathogens Training and Education Center. NETEC is the gold standard for special pathogen preparedness and response across health systems in the US, with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. NETEC's mission is really to set the gold standard for special pathogen preparedness across these innovative resources. This mission is achieved through the collaborative efforts of 13 regional emerging special pathogen treatment centers across the country. More than 100 industry leaders representing a range of healthcare specialties, from infectious disease clinicians to emergency medical services leaders, share their expertise across NETEC's 15 national work groups and 9 task forces. NETEC has several areas of focus and leverages the knowledge and experience of its regional partners to produce timely and innovative educational resources, provide technical consulting and assistance, build a nationwide special pathogen research infrastructure, and convene global partners. NETEC's international arm seeks to strengthen partnerships with global special pathogens programs and facilitates best practice sharing, primarily within the realm of high-level isolation. So now into the content. We have a very jam-packed schedule for you today, and we're going to begin with an introduction to mpox and the eye, followed by mpox in the field, a story of the DRC, as well as a DRC field response to ocular mpox, then move into infection prevention and control principles, and then emerging infectious diseases of the eye, mpox, Ebola, and other emerging pathogens. We will conclude with a brief question and answer period and an overview of NETEC resources. As a reminder, please utilize the question and answer button at the bottom of your screen in the Zoom to ask any questions that you have of the panelists, and we'll hope that we can get through your questions at the end of this session. So without further ado, I'd like to introduce our first panelist, Dr. Jeremy Seitzman, who is a clinical professor of ophthalmology at the University of California, San Francisco. She is also the medical director of the Francis I. Proctor Foundation and the UCSF Cornea, External Disease, and Refractive Surgery Fellowship Director.
Thanks for including me in this great seminar. My job is to get the party started, to talk about mpox and how it involves the eye. I would like to say that for my part, I'll do a brief introduction to mpox. A lot of the virology and epidemiology will be given to you in quite a bit more detail by the great speakers that follow me. Let's talk together about symptoms, the eye symptoms that are common in mpox and the ones that are less common. We'll do a brief overview of some treatment options for eye disease and a brief review of how we can diagnose mpox on the eye. Mpox, as we will delve into later, is a double-stranded DNA virus. It belongs to the family of Poxviridae and the genus Orthopoxvirus. It shares a lot of viral structure similarities with vaccinia, with smallpox, which is why a lot of our treatment decision-making decisions and experience with the disease parallels the smallpox story. When we talk about strands of mpox, we're often talking about clades. The mpox genetic sequence are classified into something called clade, and a clade means an organism that has a common ancestor. And so this will go into more detail later, but the clade 1 is the mpox outbreak that was the sort of OG, the original one that came out in Central Africa, 1970s and after. And then clade 2 is typically used to describe the virus that was initially transmitted in West Africa, and again, most recently. The most recent 2022-2023 outbreak is still being genetically finalized classification-wise, but we often refer to it as clade 2B or maybe even a clade 3. When we talk about mpox in the eye, we have external manifestations and ocular. And external just means eyelid, which is skin, which is the mpox rash that everyone is familiar with. When we get to the world of ocular, the eyeball, I know there are a few ophthalmologists perhaps listening and many who are not, but every single part of the eyeball can be affected by this virus. So the cornea, the clear part of the front of the eye, the conjunctiva, which is the lining, inside of the eye where we can get uveitis and inflammation on the inside can also be affected by mpox. Next. When we looked at a retrospective review from Quay to Nigeria, almost everyone had mpox lesions on their face, and of those, a quarter were on the eyelid. So a reminder that the characteristic mpox rash is maculopapular, and it progresses to vesicles and pustules before it scars. So when you have a classic mpox rash, and notably, it looks a little bit like measles and mumps and other diseases can masquerade as this. If you had, for example, an mpox rash around the eyelid and a red eye, I think many people would say, wait a minute, maybe the eyeball is affected. It gets harder when you just have mpox lesions somewhere else and a red eye, or maybe no mpox lesions at all, and we'll talk about that as well. Next slide. The incidence of ocular mpox in this new wave post-2022 is still emerging. It seems possible that there were more red eyes before 2022 than post-2022, although most of the cases that we're aware of all involve a red eye. So let's say that it's possible that the eye is involved, possibly less with the most recent outbreak, but the final incidence of ocular mpox is still being determined. Again, if you have a red eye with eyelid lesions, I think many of us can say that might be mpox being involved. And here, there's a beautiful example there, or at least in my world is beautiful, of conjunctivitis, which is called serpiginous conjunctivitis. It doesn't always look like this. This is one form of conjunctivitis. If you can hear my computer, it's revving up. I'm not so sure why. It's a little warm. And so ocular conjunctivitis can just be a red eye, or this interesting form of serpiginous conjunctivitis has been described with mpox. This is a case I'd like to tell you about. Imagine the top left in your picture. This is a patient of mine who presented with perfect skin, absolutely perfect skin, and notably was vaccinated against mpox. And if you can see, this is a selfie. On the inside of that right eye, there's a little bit of redness. We call that episcleritis. Well, that didn't go well for him. And it turned to the next picture where the sclera became almost necrotic and lots of pus and redness. And it looked infectious to us, but all of our tests were negative. So we were constantly culturing, constantly looking to see, why is this disease progressing? And you can see the pictures, there's some staining on the cornea. And then suddenly it goes inside of the eye, massive inflammation. And then from a diagnostic point of view, from our point of view, it was in a conundrum. It clearly is progressing. We tried anti-inflammatories and it made it worse. So we feel in our hearts it's infectious and we're just not getting it. We have an experimental protocol of deep sequencing at the University of California, San Francisco in our eye department. And we put a tiny needle inside of the eye because the inflammation was there. And it came back to mpox and we were floored. We weren't expecting it at all. We swabbed the lesions that were superficial and that came back as mpox. So we learned a lot about this disease, especially that you can have ocular mpox infecting every single part of the eye and absolutely no skin lesions. We talked about it can affect the outside of the eye, the sclera, the inside of the eye with inflammation. And if there's any ophthalmologists in the house, something interesting is when it affects the cornea, it tends to destroy the nerves and cause that to be a neurotrophic situation. We've talked about on the eyelid, you can get a vesiculopapular umbilicated eyelid lesion with or without conjunctivitis. And sometimes you can just get corneal involvement and uveitis. But I think the take-home message here is that vision loss in the setting of anyone who has traditional risk factors for mpox should warrant an emergent referral to ophthalmology. Next slide. Throughout the literature, there are lots of different ways that mpox can present. So we always want to just keep attuned to the fact that anyone who has vision loss and lesions, umbilicated or risk factors, could be a candidate of someone who has mpox on their eye. Next. There's no definitively established antiviral regimen for the treatment. With smallpox, we use topical trifluridine. So we use that again with ocular mpox. We also have ganciclovir gel, and some people advocate for betadine. Systemically, there's oral and intravenous tecovirimat, cidofovir, and brincyclovir. Of course, not everyone needs to be treated for systemic disease, but by the time it becomes a blinding complication, most of these people are being treated systemically. Last slide. Real-time PCR is the gold standard for mpox diagnosis. Less commonly, we use culture, serology, LAMP, CRISPR, and we have a whole genome sequencing system at some university settings. But the benefit of whole genome sequencing is sometimes in those cases where you don't expect it, whole genome sequencing is unbiased, so it can help you get to the right diagnosis. So in conclusion, ophthalmology continues to have an important role in the identification of emerging and re-emerging infectious disease. And it's exciting to just remember the important role that we all have in all of our roles in identifying these diseases, treating and preventing future transmission.
Thank you so much for that overview, Dr. Seitzman. We are now going to turn to a story of mpox in the field from the Democratic Republic of the Congo. And we are so lucky to have Dr. Placide Mbala Kigebene, who is an associate professor at the University of Kinshasa Medical School. He is the head of the Epidemiology and Global Health Department and director of the Clinical Research Center at the National Institute of Biomedical Research in the Democratic Republic of the Congo.
Thank you so much for this opportunity to talk about the mpox, what we see about mpox in the field. Most in DRC, as the DRC is the country where most cases of mpox are reported. Next slide. So what we know about mpox since the identification, the first case of mpox. So since 1917, 70 to 2016, we know that mpox is mostly reported in rainforest area, in Central Africa and West Africa, most in a rural area. And then the children less than 15 years old are mostly affected. So we have more zoonotic source than human-to-human transmission. And the incidence is more among people unvaccinated against smallpox in the past. And also we see as a clinical feature, mostly like a generalized rash illness with a fever, and also more severe cases among smallpox unvaccinated. And the case fatality rate range between 0.2 to 10%. So with the clade 1 prevalent in Central Africa, most virulent than the clade 2 prevalent in West Africa. As you can see in the map, we have more the clade 1 mostly in the Central Africa, the clade 2 in West Africa, and Cameroon is the only country where we see both clades. So you can see in the picture how clinically this disease is presenting with the huge lymph node, which also help to make the difference between mpox and chickenpox and smallpox at that time. So next slide. And we also, during our work, we show also that the people vaccinated against smallpox in the past were protected at over 80%. Next slide. So what we observed after 2016, so between 2017 to I can say 2019, this is also which kind of show the situation. It was a kind of the beginning of the situation that we are seeing now regarding mpox. So it's even though the case in Nigeria where this situation started, the first case was in a child 11 years old, almost at 30 years after the last case reported in Nigeria. But we can see that the progression of this outbreak was really different of what we knew before. So we have more cases among young adults in the urban cities. We have more human-to-human transmission than zoonotic source. And most people with STI, genital ulcer, and also including HIV patients. And we have cases starting slowly in the rainforest, but spreading out very quickly in the urban area, which is really different. And you can see in the picture how clinically the mpox was presenting at that time, and you can see the contrast with what I presented in my previous slide. Next slide. So here in Nigeria, so the first case started in Nigeria, and those cases were exported very quickly. Next slide, in UK, Singapore, Israel. Next slide, in the US, and also next slide when we see the huge outbreak in the global outbreak in the most country. Next slide, where we see kind of more than 100 countries affected, and mostly in non-endemic region of mpox. And most cases were among MSM patient and also with HIV. Next slide. The next slides. So we see this increasing number of cases also in the DRC in 2023, and this increasing number of cases continue in 2024 and also in 2025. And we observe also, next slide, we observe also a different, I can say, presentation of the disease with more cases among sexual networks. And this also led to the identification of the new clade 1B. Next slide. In Kamituga, one of the mining city in South Kivu, and this clade was a bit different with what we observed before in the country, where with a kind of sustained human-to-human transmission. And we knew before that mpox was mostly a zoonotic disease with very few human-to-human transmission, but with this new clade, we see a kind of game changing, and so we decided to follow the situation of the two clade in the country. Next slide, where we can see here in this map in yellow the way the clade 1B, mostly in the east part of the country, spreading from the north to the south, and also with a few cases in the west of the country. And in the west, we see mostly in blue the clade 1A, but in Kinshasa, where you see this co-circulation of clade 1A and clade 1B, which is also observed in a few cities in the country. And so when we zoom in Kinshasa to understand the situation, next slide, we see a kind of a two period. The first period starting 2023 with a few cases, and then the second period, next slide, starting around August of 2024 with a huge increase of cases. Next slide. So when we analyze those cases, next slide, we see that most cases that we observe in Kinshasa were among young adults. Next slide. And so which shows lesion mostly located at the anogenital part, so mostly over 60%. Next slide. So we also observe, next slide, that both clades, so clade 1A and clade 1B, the clade 1A, which we knew before was mostly a zoonotic, but we observed that both clades, next slide, are showing now more ApoB3 mutation, which may explain why now even the clade 1A is now adapted to human transmission. Next slide. So now we are facing, so we knew, this is what we knew before, clade 1 and clade 2. Next slide. So now we are facing 4 clades circulating in the continent, clade 1A and B, clade 2A and clade 2B. Next slide. And with, next slide, 3 clades, so 1A, 1B, and 2B, showing the capacity to be adapted to human transmission and are able to conduct to a kind of a huge outbreak. Next slide. So in conclusion, what we can say, next slide, that we see a shift of epidemiology of mpox, which we knew before, which was mostly zoonotic with limited secondary human-to-human transmission, but now we see a kind of a different epidemiology. Next slide. So we observe also that there are 3 clades that can spread through sexual network and also conduct to a sustained human-to-human transmission. Next slide. And we describe a new lineage of clade 1A, which we knew before that was mostly zoonotic, but we see in Kinshasa that this clade is now accumulating more apobacterial mutation, meaning that is being now adapted and suitable to human transmission. So we believe that, next slide, that all those clades, if the conditions are met, they can also lead to human-to-human transmission, even to kind of a huge outbreaks. Next slide. I think it's my last. Thank you.
Thank you so much for that introduction to the epidemiology of mpox and ocular mpox in the DRC, Dr. Mbala Kigabene. I now would like to turn it over for an overview of the DRC field response to ocular mpox to Dr. Jean-Claude Mwanza, who is a professor of ophthalmology at the University of North Carolina at Chapel Hill and the University of Kinshasa in the Democratic Republic of the Congo.
Thank you, Dr. Yaffee. After the excellent overview of the ophthalmic manifestations by Dr. Seitzman and the epidemiology of mpox by Dr. Mbala, we can now understand why eye care professionals should be part of the mpox outbreak response in a setting like DRC. So in this few slides, I'm going to describe briefly what we have been doing in terms of response to ocular mpox during the current outbreak in DRC. I'm going to share some of the challenges that we face in the field, and I'll provide a few recommendations for sustained actions to mitigate the ocular complications of mpox, given the rising number of cases. So before we started this work, there was no information on the prevalence of mpox-related ocular disease, but we knew from past outbreaks or past studies that the prevalence was higher in clade 1 affected areas, such as the DRC, than clade 2 affected areas, such as Nigeria and the rest of the world. So it all began when we were receiving messages from concerned colleagues in affected areas of the DRC between April and July 2024, that some of the patients with mpox were presenting ocular complications. So from that moment, we started gathering some information. So after we obtained some reliable information, we started meeting and preparing to travel to Congo. We were procuring for ophthalmic equipment, the PPE, all the supplies, including trifluridine, and we started the partnership with the Ministry of Health, the WHO, and all the local partners. So in August, right after, just 1 week after the outbreak was declared a public health emergency of international concern, we traveled to the Equateur province of the DRC, where we team up with local colleagues and cared for mpox patient who had ocular mpox, of course. As of now, we have worked with local ophthalmologists and other professionals to care for mpox, ocular mpox in the Equator province, in North Kivu province, and in Kinshasa province. Although we have paused our operations recently due to safety and political unrest, we have managed to arrange for follow-up with local ophthalmologists, and we have made trifluridine available for free to a patient with ocular mpox. Next. This work comes with a lot of challenges. The process of gathering information such as the expected prevalence of ocular mpox or mpox was very difficult, especially because most of the affected areas are very remote and very difficult to access, and there are no eye care professionals who can provide reliable information. This work also requires a lot of communication with multiple parties, including the Ministry of Health, the INRB, health officials at the district and province levels, and then also the WHO officials in different offices. So any breakdown in communication anywhere can derail or delay completely the planning or the execution of the work. So from the operational standpoint, ophthalmic equipment are either not available or not functioning, meaning everything has to be brought in. And also there is frequent power outage, meaning we can't even use the standard equipment like slit lamp. Next. So the biggest challenge is working in a conflict or in a war zone. The DRC has been on level 3 or 4 of the U.S. Department of State for a very long time, and recently it was upgraded to level 4, which means do not travel. So they're asking people not to travel to DRC. And also there was a recent escalation in fightings in Eastern DRC in some of the cities that we visited, and also political unrest in Kinshasa, which led us to pause our operations recently in January 2025. Next. So these are the pictures that we received from the field before we decided to go. Actually, these pictures convinced us that there was an issue and that we needed to respond. So you can see this woman with bilateral blepharoconjunctivitis, a 16-year-old boy with conjunctivitis, a toddler here with teary eyes, and then this young boy also with necrotizing corneal ulcer, and another one with keratoconjunctivitis. Next. So what we have observed so far in the patient we have seen is similar to what has been described in the literature, such as the first picture here, the peri-orbital or periocular lesions, eyelid lesions, conjunctivitis that can be sometimes sur-infected. And we saw every type of corneal lesions from superficial to corneal scar, staphyloma, and perforation and loss of vision, of course. I'm just realizing that this picture, the last picture here from Dr. Saltzman is going viral now. I've seen it in several reviews on ocular mpox. And thank you, Dr. Saltzman, for providing this picture. Next. So our November trip to the DRC coincided with the 21st Congress of the Congolese Ophthalmologic Society. So I would like here to thank the organizers for inviting us to speak. So we organized two sessions where Dr. Karag spoke about PPE and IPC measures. Dr. Ye gave a lecture on emerging infectious disease and the eye, and Dr. Linderman presented some findings on ocular immunology in these infections. And these sessions were followed by a very good and interesting discussion. So in conclusion, mpox is associated with an array of ocular manifestations, and among those, conjunctivitis is the most frequent within DRC, and this has been going on for many years. So given the rising number of cases and threat to vision, and the difficulty to access some of the area or most of the areas affected by the mpox, a concerted effort is needed among all stakeholders. And there is also a need for increased awareness among healthcare workers and patients about the ocular symptoms and preventive measures. Thank you very much.
Thank you so much for that overview, Dr. Mwanza. I'd now like to turn it over to Dr. Jessica Karag, who is the Program Director for the Emory University Serious Communicable Diseases Unit, and she will be discussing infection prevention and control principles for ophthalmic mpox.
Thank you, Anna, and thank you to my fellow panelists for that overview of ocular mpox. We're going to turn the discussion now to infection prevention and control principles, which should be relevant to just about any healthcare worker seeing a mpox patient, regardless of ocular involvement, although I will go into a little bit more ocular detail later. Next slide, please. So the virus that causes mpox, I like to say it's long to linger, but easy to inactivate. So pox viruses in general are known to be persistent for long periods in the environment. Variola and vaccinia viruses, which are very closely related to mpox, have been shown to stay viable for months to even years under controlled environmental conditions. And for mpox, CDC conducted a household environmental sampling study in which they sampled the household of a patient with mpox 15 days after that patient had vacated, and they did find viable virus on certain surfaces. But the good news for my virology enthusiasts out there is that it is an enveloped virus, so it's relatively easy to inactivate by using the proper disinfectants and cleaning procedures, which I'll get into. Next slide. So when thinking about infection prevention and control for any pathogen, it's essential to understand the routes of transmission. So for mpox, contact transmission is the primary form of transmission. This can be through direct or indirect contact with lesions and lesion materials like rashes, scabs, and fluid from the lesions. It can also occur through respiratory droplets and likely or possibly through other body fluids, including potentially tears and ocular secretions. And of course, anything contaminated with these infectious materials like clothing, linens, non-porous surfaces, and equipment can serve as a method of transmission. Additionally, mpox has been shown to be possible to transmit via airborne routes. However, this is likely a less efficient and much less frequent form of transmission, but there have been documented instances in both humans and animals. Additionally, mpox can be transmitted vertically or through exposure to infected animals. Next slide. So as a healthcare worker, you want to keep yourself safe. So in addition to using standard precautions, which I'll go into more detail on, some mpox-specific precautions to take once you identify a patient with suspected or confirmed mpox infection, you want to notify your infection prevention and control personnel at your facility. And you'll place the patient in a single-person room with the door closed and a dedicated bathroom when possible. If performing any aerosol generating procedures, these should be done in a negative pressure airborne infection and isolation room. Next slide, please. Additional measures you can take. Source control can be extremely important, especially when performing ocular exams on patients. Remember that respiratory droplets can be infectious. So if you're up close and personal with the patient performing an exam and they're talking, laughing, coughing, they're exposing you to all of those respiratory droplets. So a medical mask is a great way to mitigate this, a medical mask on the patient. Additionally, you can try to cover exposed lesions with a clean sheet or gown when possible. The minimum personal protective equipment recommended by CDC for any healthcare worker entering the patient room would be a gown, gloves, a NIOSH-approved particulate respirator such as an N95 or higher, as well as eye protection that covers both the front and the sides of the face. And you don't want to forget about basics like hand hygiene, washing an alcohol-based hand rub, and of course, because mpox can linger in the environment and it is readily transmitted through contamination, you want to stay aware of what both you and the patient has touched so that you can kind of follow that contamination around and determine whether it's gotten on equipment and surfaces or even yourself and your PPE. And I did note that vaccination is also a potential way to protect yourself. It is recommended for certain at-risk populations in addition to certain healthcare workers. Next slide. So protecting others through environmental disinfection. You want to clean and disinfect equipment, surfaces, rooms, linens, per protocol, per your facility's protocol, with an EPA-registered hospital-grade disinfectant with an emerging viral pathogen claim. So for those of you who are not familiar, there's multiple emerging viral pathogens who are grouped into this category, meaning they do not have a specific claim against them. Or in other words, you won't see mpox listed specifically on the label of the disinfectant. So you'll want to check this list for approved disinfectants. On the EPA website is list Q. And of course, always use disinfectants per the manufacturer's instructions. Avoid any activities that could resuspend dried materials like fans, dusting, sweeping, shaking linens. And a note about waste for clade 1 or clade 2 mpox patients, the waste can be disposed of as standard regulated medical waste. It is category B. The only exception would be laboratory cultures of clade 1 mpox, which are category A. And protecting the patients, so ocular specific considerations. Remember that ocular secretions and tears may potentially be infectious, and additionally, infectious lesions can present around the eyes. So you want to be careful to protect patients from cross-contamination or auto-inoculation of the eyes. So ways to mitigate this would be to clean instruments between use on individual eyes and work from the clean eye to the dirty eye if only one eye is affected. Avoid touching facial lesions when manipulating the periocular area, or if that's unavoidable, such as in the patient pictured below, you can try to use a clean barrier, like a piece of sterile gauze, to avoid coming into direct contact with the lesion material. Advise patients to avoid rubbing their eyes, to practice frequent hand hygiene, and to avoid use of contact lenses to prevent auto-inoculation. And be careful about things that could potentially transfer contamination between eyes or even between patients. So things like multi-use eye drop bottles. One easy method that could be utilized is to occlude the superior mask gap when administering eye drops. This can prevent exhaled air from coming into contact with the eyedropper tip. Or if possible, you can also try to avoid the use of multi-use eye drop bottles. And finally, it's most important to have a plan before you walk into the room. Think about what you're doing, what tasks you'll need to perform, what supplies and equipment you'll need to bring in with you so you can avoid walking back and forth and potentially spreading contamination between clean and dirty zones. And think about things like, will you have assistance, someone there to help you both perform the exam, but also to serve as an extra pair of eyes to spot potential contamination events. So planning this interaction ahead of time can help minimize the risk to you as the healthcare worker, as well as the patient and to the general public. Thank you.
Thank you, Dr. Karag. We'll now move on to our final presentation, Emerging Infectious Diseases of the Eye, Mpox, Ebola, and Emerging Pathogens, by Dr. Stephen Yeh, who is a professor in the Stanley M. Truelson Jr. Chair in Ophthalmology in the University of Nebraska Medical Center's Department of Ophthalmology. Through UNMC's primary clinical partner, Nebraska Medicine, he also serves as director of the Retina and Uveitis Service.
Great. Thanks so much, Dr. Yaffee, and a really fantastic overview of IPC from Dr. Jessica Karag. I think that many of these lessons are translatable to other pathogens. And so I'll be taking a step back as we think about Mpox as related to other emerging infectious disease that are of profound public health and individual patient importance. So in the first way of overview, first I'll talk about some of the vision-threatening consequences again related to not only Mpox, which we've been really nicely summarized by Dr. Seitzman and Dr. Mwanza, but also looking back at Ebola virus disease, other emerging infectious pathogens. Also discuss the context of recent and ongoing outbreaks that have really informed our approaches more broadly to vision-threatening sequelae of Ebola, Mpox, and again, these pathogens of public health importance. Next slide. So all of us are probably all too familiar with the global impact of these emerging diseases, with the outbreaks of measles within the United States, Ebola virus within Western Africa and Central, as well as Sudan Ebola virus in Eastern Africa, as well as the Mpox outbreak that is currently ongoing. Next slide. But I'll submit to you that the eye really represents a unique window to these emerging infectious diseases. Dr. Seitzman mentioned the extraocular manifestations of Mpox, predominantly keratitis and uveitis is pictured in the central photos on this slide. But Ebola can lead to intraocular inflammation, really a spectrum of uveitis ranging from anterior uveitis to panuveitis, involving all the tissue layers of the eye. A number of our colleagues from the CDC have characterized very nicely the high rate of conjunctivitis with H5N1 or highly pathogenic avian influenza, again, illustrative of the range of ophthalmic manifestations that we can see with these emerging infectious pathogens. But really it starts with the individual patient. And this is a young girl that we had the opportunity to take care of within Western Africa. Her name is Aminata Kante, and she was about 7 years old when she was photographed by this reporter who came out from the New York Times. And you can see that in the right eye, after this young girl, Aminata, had survived Ebola, she developed a severe vision-threatening cataract. You can see the whitening of her lens structure with posterior synechia, which is scarring from the iris to the lens. Next slide. And it's hard to believe that it's been over 10 years since healthcare workers were repatriated first to Emory University and subsequently to the University of Nebraska. But again, these were the heroes and some of the faces that we saw again just over 10 years ago. Dr. Ian Crozier was one of these heroes who actually emerged from critical illness at Emory University. And his story has been widely publicized. Next slide. But you can see that in the context of Ebola recovery during convalescence, this is fully 3 months out after his acute infection, he developed a severe sight-threatening uveitis. First, he had an anterior uveitis with elevated intraocular pressure, what we call an acute hypertensive anterior uveitis. You can see on the left-hand side of your screen. And he quickly progressed over about a week and a half to 2 weeks to a severe sight-threatening panuveitis. You can see the coloration change of his iris during this time. And we eventually treated him with a number of experimental antiviral therapies as well as different types of corticosteroids. Next slide. It really was in this context that we started thinking further about persistence of virus within the eye. We identified Ebola virus within the aqueous humor. Again, this is fully over 3 months out after he had developed acute infection. This lesson related to persistent viruses is a theme that we see not only with Ebola, but other RNA and DNA viruses as well. And it's also important and relevant to mpox as well. Next slide. And so further along, as we start to understand this process in Western Africa, this is from some of our colleagues at the NIH. This is the PREVAIL-3 study, where they evaluated nearly 1,000 Ebola survivors and a close contact control group. And what they found was that over 25% of individuals who had survived Ebola actually developed evidence of ocular inflammation or uveitis. At the 1 year time point, they actually had an increase in the prevalence of disease to about 1 in 3. Unfortunately, many of these patients lost vision from a variety of secondary sequelae of intraocular inflammation, including cataract and neovascular glaucoma. This is a program that we're currently continuing with a parallel study within Sierra Leone. Next slide. But it turns out that Ebola virus persistence not only persists within the eye, but also can have different ramifications from the standpoint of public health. Dr. Mabala talked about the issues related to mpox persistence and transmission from reproductive organs and sexual transmission, but Ebola can also persist not only in reproductive organs, but also in the central nervous system, giving rise to meningitis with recurrence, and also placenta with implications there related to maternal death and stillborn infants as well. So how does this relate to mpox? Well, Dr. Seitzman and Dr. Mwanza again illustrated this broad range of ophthalmic implications, ranging from these periocular umbilicated lesions to conjunctivitis, keratitis, and keratouveitis in some situations. But it turns out that there have been a number of studies, including Dr. Seitzman's, that looked at PCR both on the ocular surface and also within the eye. This is the study that Dr. Seitzman reported on earlier of this patient with very, very severe disease, and they showed that mpox was confirmed within the sclera and the cornea by PCR, as well as sequencing evidence of mpox RNA within the aqueous humor. Another more recent study by Finnemore and others in International Journal of Infectious Diseases actually showed the presence of replicating mpox virus that was identified in 5 patients. The time point actually ranged anywhere from 1 month up to 5 months after the first skin lesion was identified. They looked at over 20 samples and found mpox virus in a variety of these samples, both ocular surface and as well as the aqueous humor. The CT values ranged from 24 to 35, and what they found was that when the CT value was around the range of 33, it turns out that mpox virus was actually replication competent and actually could be culture positive as well. So how do we begin to address these implications within the DRC? Dr. Krog really illustrated a lot of these principles related to infection prevention and control. And these lessons are really translatable not only to sub-Saharan Africa or Western Africa, but also within the United States as well. Thinking about factors including source control, the use of appropriate PPE as recommended from Dr. Krog's slides. Also with ophthalmology, you also have issues related to equipment handling, precautions, as well as disinfection practice as well that are also relevant to the care of patients. Moving forward, within Sierra Leone, we've developed a long-term study of ocular complications for Ebola. And again, with the range and the scale of patients that are involved in the DRC, these are the types of initiatives that are needed, perhaps even at greater scale, given the numbers that Dr. Mabala reported previously. Next slide. But it turns out that beyond the medical care, surgical care is sometimes needed as well, with the severe corneal scarring and corneal pacification that's needed. Robust surgical infrastructure can also be needed. There can be a number of obstacles that are along the way. This is an example of the vitreoretinal surgical infrastructure that we've established, but logistical hurdles including heavy equipment, supply chain, as well as capacity building as well. And as we look at the future of infectious eye diseases, certainly other diseases that are on our public health radar include syphilis, which can lead to a chororetinitis, tuberculosis, which can lead to large choroidal granulomas and choroidal inflammation, as well as toxoplasmosis, which is the #1 cause of infectious uveitis worldwide. And when we think about Ebola, mpox, Ebola with the uveitis, mpox with the keratitis and uveitis, there are other vector-borne illnesses that, again, for the sake of time, we won't mention, but important to think about chikungunya and dengue, and also Rift Valley fever we see in Eastern Africa and in the Middle East that can also lead to a retinitis in addition to its impact on patient populations, human patient populations, and livestock. Thank you again for your time, and I'll turn it over to Dr. Yaffee for the discussion and Q&A. Thank you.
Thank you so much for that closing presentation. I would now like to invite all of our panelists to come back on your video screen for our Q&A session. And as a reminder to our audience, feel free to use the Q&A tab at the bottom of your Zoom screen to ask any questions of our panelists that you may have. We do have a question in the Q&A. I think this question maybe Dr. Seitzman could answer. At what point in mpox ocular infection is sight still salvageable?
Appreciate the question. I like the fascinating and horrifying because it still secures job security for me. From ophthalmology, we just say fascinating. The red eye component. So when mpox affects the eyelid, sure, vision is unlikely to be affected. When mpox involves the conjunctiva, so you get a pink eye, it's irritating. Patients are symptomatic, but it would be very unusual for that to be visually threatening. And conjunctivitis is by far the most common ophthalmic manifestation of mpox. When the virus gets on the cornea, then we start to get into some trouble, especially because for reasons that we don't fully understand, the virus seems to destroy the corneal nerves. So the patient's not capable of healing as quickly as they should be. And they are more prone to secondary infections when they become neurotrophic. So once the virus starts to invade the cornea, I would say you're at risk of vision loss. And then certainly when the virus gets inside of the eye with uveitis, the rate of vision loss gets higher and higher. Now, certainly in areas with resources, when you have a large corneal scar and we get through the infection, we can do other surgeries such as corneal transplants to try to restore vision. It is never as good as before the infection. So there are still oftentimes some things we can do to restore some vision. But once the virus destroys the full thickness cornea or gets inside of the eye, then we're starting to worry about irreversible vision loss. Thank you for the question.
Excellent answer. We have another question in the chat about many patients with mpox who developed a persistent maroon cornea ulcer. The question asker is wondering if you could share a little bit more about the treatment of this ulcer after mpox. I don't know who's best to answer.
This is really interesting. I'll start, Chanel, and then I'd like Dr. Mwanza to take over locally. That is surprising. So from your question, it sounds like there's a severe peripheral corneal ulceration that looks Morin's-like. So if it were a true Morin's ulcer, for people who aren't ophthalmologists and corneal specialists, this would be an immune-mediated, severe thinning, aggressively inflammatory process of the peripheral cornea that is treated with immune suppression. But it sounds as though there's a Morin's-like ulcer that is presenting in the setting of active infectious mpox. If that's the case, I would say it's a Morin's-like disease, and that very thorough, prolonged antiviral therapy would be required prior to even the thought of systemic immunosuppression. There are very nuanced processes in uveitis where we treat the infection first, and then we deal with the secondary inflammatory complications, and I suspect this is something that you would be dealing with then. But in the setting of active mpox, and it looks Morin's-like, I think we all have to presume that this is a prolonged infection, and the treatment would likely have to be systemic and prolonged. Dr. Ye touched on it a bit with persistent PCR positivity of the lesions. At our institute, we've also done RNA sequence analysis of those lesions, indicating that there can be prolonged viral replication on the eye for months and months and months, which would mean that the patient would require prolonged antiviral treatment, again, before any anti-inflammatory treatment is considered. That's a very interesting presentation that we haven't seen in the United States. I'd love to learn more about it, and I would love Dr. Mwanza's thoughts as well.
I agree with your answer. I think the issue is in mpox, you'll have these peripheral ulcers that may look like Morin's, but they are not. But I think the key is to conduct a good history in a patient who has a recent history, who is currently having mpox. Then we may think about mpox-related ulcer. If not, then we have to make sure that it's not mpox, and then look if it's murines, because the treatment are clearly different.
Thank you both. I think we just have time for one more question, and we do have another from Jill. How protective is the vaccine for preventing eye infection? Maybe Dr. Ye to take this one?
Yeah, that's a good question. I think that at least thus far, we know we have the data obviously from the detection of Jynneos for systemic disease. I don't think that at least in terms of just the capacity and scalability of what's been deployed in DRC, that we have that data as of yet. But at least in terms of just thinking about immunologic pressure and potential for viral change, that's one question I think that could come up down the road. I don't know that there's clear evidence related to how vaccine has modulated the effect, although I think that clearly it does, you do see immunologic change and some protective effects from a systemic perspective.
Well, I know we're right at the top of the hour, so I want to thank all of our panelists for your excellent presentations and your knowledge. I think you really stimulated a lot of thinking in our audience and a lot more questions to be answered. I do want to highlight a couple NETEC resources for everybody involved. So NETEC does offer support services, so you can submit a technical support service request at netec.org, or you can email info@netec.org. So you can submit this request online, and then contact us anytime you have a question, need support, or any services. So again, we are here to help. So please send questions, submit technical assistance, because we really have a lot of subject matter experts that are interested to help you be more prepared at your own facilities. We also have several modalities of contact. So we have lots of social media options. So please follow us. Also, our podcast, Transmission Interrupted, is a great way to get some special feature information and then skills videos online. And then in our resource library, we have shared lots of resources that our facilities use, as well as from around the world of opportunities for prevention and preparedness. So with that, I will close. Thank you so much for your participation, to our panelists for their knowledge and expertise, and we look forward to seeing you at a future NETEC webinar. We hope you have a great day.